Thank you for coming. Ach bhí núsla tá fáilte rót ag scoil na hátrachta chnéimhnachas agus chorasláinte cláiste Ollscoil Palliative. It's my pleasure to welcome colleagues, graduates of Palliative Care Education from UCD and Our Ladys Hospice, and some current students to celebrate 21 years of palliative care education here at University College Dublin, particularly the School of Nursing, Midwifery and Health Systems, in collaboration with the School of Medicine, and at Our Ladys Hospice and Care Services at Harold's Cross. I'd like to acknowledge the contribution made to palliative care education, and particularly the course that we run here in partnership with our colleagues at Our Ladys Hospice and Harold's Cross, in particular the Director of Education and Research, Patricia Halloran, Dr. Mary Bell and Anita Duffy, who are tutors there. I think it's fortunate that only a week ago we celebrated International Women's Day, and it is to two visionary women that thanks must be extended for developing the first post-registration programme of study in palliative care, at the time developed for nurses. I speak first of Sister Frances Rose Flynn of the Irish Religious Sisters of Charity. For those fortunate enough to know Frances Rose, they'll be aware of her support of and devotion to the development of education to enhance patient care. This was evident in her work in the School of Nursing at St. Vincent's University Hospital, but also in her tremendous vision to establish an education department at Our Ladys Hospice. I was personally lucky enough to have known Sister Frances Rose, and also to have benefited from her wisdom and her counsel, and indeed her encouragement of me to take the job that I was offered here in UCD. At the time she said to me, "We might be losing some of our best, but you'll still be working with us, only in a different way." I want also to acknowledge the work of Miss Anne Hayes, who I'm delighted to say is here. Anne was the nurse tutor who championed the development of the first programme, and that first programme was offered over 2 years, the first year being supported here in the university, with the second specialist year devoted to specialist palliative care education being provided at Our Ladys Hospice. I do suggest she was ably succeeded by my colleague Professor Larkin, who was called upon to fill Anne's shoes when he was appointed to the role of tutor at Our Ladys Hospice in time to support the second year of the programme in 1998. So we come together today to remember and to celebrate, but also importantly to reflect on the journey to this very prestigious day and the continued journey to come. And so without further ado, it's my pleasure to welcome Professor Cecily Kelleher, who is Principal of the College of Health and Science, Agricultural Sciences, who will open our celebrations.
Michael, thank you. Colleagues, distinguished guests and friends, it gives me great pleasure on behalf of Professor Andrew Deeks, the President of UCD, who's travelling in Boston this week, to welcome you to this excellent meeting to celebrate 21 years of palliative care education at UCD and Our Ladys Hospice and Care Services. The UCD School of Nursing, Midwifery and Health System, as you know, has a long and proud tradition of providing high-quality clinical and academic programs for nurses, midwives and health and social care professionals. As a dynamic interdisciplinary school, our programs emphasise clinical expertise, critical inquiry, leadership development, personal growth, communication, teamwork, interprofessional collaboration, and lifelong learning. The school's programs are delivered in a friendly and a collegial environment by expert faculty committed to excellence in education, underpinned by research, scholarship, and to prepare our students to be expert and compassionate clinicians, inspiring and supportive educators, cutting-edge researchers, and dynamic network leaders. Health and well-being is a lifelong life course concept, and palliative care has been a focus of the school's education and research since the first palliative care education programme was established in 1997 in partnership with Our Ladys Hospice and Care Services, a valued collaboration which continues today. Since 1997, over 500 students have completed studies in palliative care. Many of these graduates have assumed leadership roles in the field of palliative care, while others continue to provide expert and evidence-based care to individuals, their families, those living with a lifelong or life-limiting condition. And over the past 21 years, the original programme has developed from a higher diploma to an interdisciplinary graduate diploma master's in palliative care programme. Given the reality of demographic change and the nature of chronic illness, palliative care is fast becoming a much-needed component for the effective management of complex care needs. This symposium celebrates the attainment of the 21st birthday of palliative care education, provided in partnership by the UCD School of Nursing, Midwifery and Health Systems and Our Ladys Hospice and Care Services. It offers a timely opportunity to celebrate a programme and a significant milestone by bringing together graduates of the programme, many of whom are here, relevant stakeholders from across the island of Ireland and experts in the field to engage in discussion and dialogue on the 3 key priorities for palliative care for the future: research, education and contribution to nursing to palliative care. We have an outstanding set of speakers in the programme, and I thank you all very much indeed for making the journey here today, and I'm sure this will be an excellent and engaging morning for all. Thank you and welcome.
Thanks very much, Cecily. I'd now like to welcome Professor Gerard Feely, Head of School and Dean of Nursing at UCD School of Nursing, Midwifery and Health Systems, to say a few words.
Thank you, Michael, and thank you, Professor Keller, for your nice opening remarks. It's my great pleasure to welcome you all this afternoon, or this morning. Our distinguished guests and speakers, our alumni from 20 years past. I'm 21 years in UCD, so I have a special affinity with this program too. I want to particularly thank our colleagues here in the school, Dr. Michael Connolly, Professor Phil Larkin, Maria Flanagan and Suzanne Keeley, and all involved in the school, and our co-hosts at Our Ladys Hospice and Care Services for the planning of this event and this program. Palliative care is a multidisciplinary field of practice, education and research, and I think the program today will demonstrate that clearly. So it's a real great pleasure to welcome you and to thank our co-hosts for this event. I sometimes refer to programs in this school as flagship programs, and I'm always including this program as a flagship program. It really is one of our marquee programs, and I wish it continued success for another 21 years and beyond. So have a great symposium, and I wish you a very successful day. Thank you, Michael. Thank you.
Thanks, Gerard. I'd now like to call on Ms. Audrey Houlihan, the CEO of Our Ladys Hospice and Care Service, to say a few words.
Thank you, Michael, and good morning all. I'm so delighted to join you today representing Our Ladys Hospice, along with many of my colleagues, both past and present, that have contributed to this great partnership throughout the years. We don't celebrate achievements enough, and I applaud UCD for gathering the good and the great of the palliative care sector here today to mark a wonderful partnership over 2 decades. I think the partnership is a model of positive collaboration with the best of both organisations, enabling students to grow and flourish through academic learning and exposure to practice through clinical placements over the years. The strong working relationship with Dr. Michael Connolly as Programme Director has enabled this relationship to grow, and the flexibility and commitment shown is second to none. I commend people that have been involved along the journey, Professor Helen Burke, Pearl Tracy, for their vision and dedication to our services, as without them, we would not have our state-of-art education and research centre that we have today in Harold's Cross. The benefits to both organisations are significant and have led to developing future leaders and shining lights for the palliative care sector. And on the hospice side, it supports succession planning, career pathways, and the attraction and retention of wonderful staff. The progressive and dynamic nature of the collaboration has been demonstrated through the creation of joint appointments. The Professor of Clinical Nursing, who we all know and you're going to hear from today, Professor Philip Larkin, and the Joint Chair in Medicine are 2 of the many achievements and the shining examples of how the journey has evolved through the years, and we hope to continue that into the future. They have made a considerable difference to the sector. As leaders instrumental in the establishment and ongoing support of the All-Ireland Institute of Hospice and Palliative Care, which has led to raising the bar in education and research throughout Ireland and embedding the learnings in policy and practice. I look forward to a very bright future of ongoing collaboration, working, vision and ground-making progress for the sector. Thank you all.
Thanks, Audrey. I'm conscious that both Professor Kelleher and Professor Feely have been invited to attend another important event which is very much linked to the world of palliative care, the launch of the Perinatal Research Centre at the National Maternity Hospital. So they're leaving us now. So we're now going to move to the more formal part of our symposium. Can I invite all tweeters to tweet and use the hashtag Palliative21 as you're tweeting, and we'll get some acknowledgements in the world of Twitter. So I'm delighted to introduce our first speaker, Professor Sonja McIlfatrick. Despite injury, Sonja made it. Sonja is a clinical academic with experience in nursing and palliative care practice, education and research. I am honoured to call Sonja both a colleague and a friend, having worked with her in the All-Ireland Institute of Hospice and Palliative Care, where Sonja headed research and I education. Whilst working with the All-Ireland Institute for Palliative Care, Sonja led the establishment of the All-Ireland Palliative Care Research Network and continues to act as a member of the Strategic Scientific Committee for the Palliative Care Research Network. As well as being an academic, Sonja has recently been appointed head of school at the School of Nursing in University of Ulster. And Sonja continues to publish widely in academic and professional journals which focus on palliative care research and has a fine and successful track record in grant acquisition. Sonja is also a keen leader and has a profound interest in doctoral education and is currently president of the International Network of Doctoral Education in Nursing. Sonja's presentation today will address palliative care research, lessons from the past and considerations for the future.
Okay, good morning everyone. Well, I am delighted to be here despite my injury. It just shows you Michael is very, very persuasive in actually invite. But I almost feel like it's almost like coming home in some ways for me, because as Michael has alluded to in my time working with the All-Ireland Institute, and I will touch on some of that this morning as well, because it's I suppose it's a very exciting time when you think back in 21 years of palliative care education here within UCD, but also if you reflect even on the last, I suppose, 10 years on a lot of the work that we've been involved with and other colleagues who are here and in the room about thinking about how we could work and collaborate together, because we are on one island, and it's actually trying to bring forward the whole research coming through in palliative care from the island of Ireland. So I'm delighted to be with you here this morning. So whenever Michael had got in touch and said about a focus around research, I was very much thinking, well, okay, you're obviously celebrating a big birthday, and sometimes when we hit milestones in our lives, it's time to maybe step back and take some reflections, think from the past and take lessons that sort of someone had said. I was at something more recently last week, and it's like, you know, learning and moving on, taking the learning and moving on, because you need to look and take time to reflect and think. Some things work really well, some things perhaps less well, and then it gives you an insight to think how you might think towards the future, which we need to be mindful of as well. So really this morning what I just wanted to think about was just to have, I suppose, a reminder about what is the importance of research. And as Michael in my introduction said, I'm a professor of nursing and palliative care in Ulster, but a lot of what I've done is been very involved in research and would teach research methods to nursing, to other colleagues. But again, going back to, I would very much say I'm a researcher. And research in my own area obviously comes there, but I am profoundly interested in research and always had. And whenever I teach and do research and with different specialist nurses and when they're doing their programs, they would sort of say, research. And I said, well, no, but it is of vital importance. And I'd just like to allude and talk a bit about that, why it's important to us, not just as a nursing profession, but also for our practice and what we do. But there are challenges in undertaking palliative care research, and I'd just like to touch on some of those. And then more specifically move from those wider issues into thinking about, okay, what's the state of palliative care research in the island of Ireland? And I'm going to draw on some work that I've been doing around 2 systematic reviews of the evidence. One from Previous, which we published in 2013, and then one that I've just submitted for publication now, taking on for the last 5 years, just to get a sense of, and I suppose that's really looking at what is the state of play now for palliative care research in the island. And then looking towards the future and the importance of effective collaborations, because no man is an island, and really to take forward research, whether that be the importance of interdisciplinary research, whether it be across different institutions. I want to sort of us think about how do we focus and build on our collaborations. So looking back, and we do have some of the very early studies in palliative care, and a lot of the history of that was we had single centre studies. And if we think about, obviously, the founder of the modern hospice movement and Dame Cecily Saunders, a lot of what, when you think of the foundation establishment, and if you read some of the texts around there for the foundation of St. Christopher's Hospice, a lot of it was largely observational. It's like, what's happening in practice? What's going on? What's, if we look at this medication, or maybe manage this symptom with this drug, the use of morphine, the use of diamorphine, those sorts of questions that came very much from clinical practice, but were very much based, if we think of the studies, and the earlier studies that were there, were largely observational. They were very much led by key champions, and you probably can think through some of the seminal texts, and I will allude to some of them in my next slide. But even, in the focus on bereavement, for example, and Colin Murray Parkes, and aspects about awareness of dying, Glaser, and those key people that you can actually think through. And if we think of Cecily Saunders' original vision, it clearly stated, and very clear, that research was integral to hospice care. The foundation question is asking, why do we do something? So research is about generating questions and looking at having questions of our practice and having that critique of what we do and why do we do it in this way. So having that critical inquiry is there, and that critical mind to ask, why do we do things in this certain way? Why would this work? Why does it not work? And those ultimate questions, to not just take the status quo and say, this is how we do things. Why do we do things that way? So fundamentally, a lot of the earlier studies that were there. And one of the key aspects was the work and the example that we could draw on from the work of John Hinton. And that's going right back. So John Hinton worked in palliative care, but he was a psychiatrist. And at that time, he started to push the boundaries in society at that time by asking questions around death and dying. And one of his earlier pieces that was published in 1974, but some of his works originated towards the end of the 1960s, was very much looking, and he found that whenever he did this work with cancer terminal patients, that they were fully aware of what their prognosis was, as in they were aware and wanted to discuss the aspects of death and dying against a context where they weren't really being given information. So it was alluding to this part, and if you think again of Cecily Saunders' work in the total pain concept, it was actually thinking, okay, we know the physical aspects there of dying and the challenges there, but what about the spiritual? What about these existential questions? What about how we view and care for people who were moving towards death and dying? So very much a pioneer in trying to push from society and asking some of those questions, and the importance about talking to people about dying and talking with people about dying. But you could say, why do we bother? So why do we need to have palliative care research at all? I'll argue that why would you not? And I think in order to survive, and the importance of it, and I will talk about a report that's come through from Focus Within Hospice and hospice care, it's can you really afford not to be involved in research? So one of the questions is that research in general does generate new knowledge. If you go back to the original definition of the term research, and it goes back and we go to, it's like French for rechercher, and my colleague here, my eminent colleague, will know much more in terms of, and obviously Claudia as well. But it's like to look again at something. So it is about generating new knowledge and about the contribution to knowledge within a field. But it can lead to improvements in practice. And one of the key examples we do have is symptom management. But again, I'd like you to think about symptom management in the broadest sense. So we have had a lot of developments in the types of drugs that we would use, in aspects of pain and pain management, and building on, you know, all the whole iterations of how you have drug interactions and all of that, and maybe how you manage symptoms such as breathlessness, cachexia, constipation, all of those. You could list those physical ones, but I'd like you to also think about complete holistic care within that. But we've had various developments and improvements. It leads to developments and improvements around how services are organised. So again, I know if you take the context here in Ireland, and I know your national clinical programme, and you think about how you had services and how you're going to construct services, you need to have an evidence base for that. And in the context that we work within, if we have a commissioner of services, if we want to have looking at how effective it is, I know we have Charles here with us in the audience, but looking at the cost effectiveness of these different models is important in order to be able to generate and look at new services and think about, well, how does that respond to the needs of those particular groups, and whether that be different groups of people with other non-malignant conditions. But does this model of service and health service model, how do we know that this has an impact not just on the outcomes for patients but also in services, because that's the world that we're in, and the importance of looking at cost effectiveness as well. And fundamentally as well, another aspect in relation to research is that it's a factor that helps to demonstrate our professional expertise. So if you think about how palliative care and palliative medicine and the specialty of palliative medicine has evolved in palliative nursing over the last 20 years, 21 years here in UCD, a key aspect is around it helps us to demonstrate the professional aspects of what we do and to be able to demonstrate the effectiveness of what it is. So there are key reasons why we would bother. So what has it achieved? What sort of aspects, if we were to have a whistle-stop tour of what types of research has been undertaken, what has it achieved over the number of years? So we know in terms of our developments, improvements in symptoms, and particularly pain control. We know in knowing a lot more around the prevalence and control of symptoms. Questions around place of death, place of care, those elements, we've got some evidence now in relation to that. We've significant evidence around bereavement and bereavement care, and anticipatory bereavement, maybe complicated grief, uncomplicated grief, those sorts of questions. We know we've some evidence there. We have considerable work around the needs of carers and looking at, and you can all probably pick out names that will come to your mind for some people who've led some of this work, but again, studies of carers looking at, carer support needs. What are they? How do we best meet the needs of carers? How do we adapt models if we know that these are the needs of this group of carers? For example, maybe carers of people with cancer and advanced cancer, to carers of people with heart failure, to other chronic conditions. A lot of work there. We've had a lot of work and some work in relation to specialist palliative care and the whole contribution of what specialist palliative care can provide and the outcomes and the evidence for specialist palliative care vis-a-vis generalist palliative care and the evolving work needed within there. We have work within communication skills, and again, if you think Susie Wilkinson's work, breaking bad news, how we build on all of that, we have that contribution there. A lot of work has come in. Well, what are the needs? What are the needs of patients? What's their experiences? Qualitative work that helps us understand how patients and their families of various groups deal and think about this aspect. Assessment tools, you could probably cite a whole lot within your mind, but again, if you think about the work led through Irene Higginson's group, and thinking about, the IPAWS and all of those, the ESAS tool, all of those tools that actually are assessment tools that are used for different reasons, and maybe holistic assessment, PEPSI tool, all of those, there's work that's built there. Significant work taking forward and ongoing around advanced care planning and the tools that are there, the use within your context here in the south of Ireland about thinking ahead, and the Irish Hospice Foundation, but trying to build an evidence base around those tools there. So there's some large European studies that are looking at the use of advanced care planning within oncology, for example. But what the evidence coming through is that while we know this is, from our point of view, we think it's very important and should be broader than just maybe symptom focus, that for patients and families, it's about what their care needs might be, and anticipatory care as well. Then thinking about conventional care, and also the whole having research that is informed by and informs policy and actually has an impact on some of those policy issues. So these are some aspects of what the research to date has achieved. But in everything, there's challenges. And I suppose things are worthwhile doing, you're going to have challenges in there. But I'd like to just touch on, I don't have the time to go through all of the challenges there, but I just want us to think about some of the key challenges that you may encounter. And for those of us who have been involved in research over the years, at various times, these are aspects that we've come up with. I would argue clearly that we have ways to address all of these challenges, but it's just they're ongoing. And there might be reasons why people would say you don't do research within that area. So one of them, for example, is ethics. And I'll touch on some of that because sometimes people would question, is it ethical to do that type of research at that type of time when the patients are quite ill and you know, you're coming in and asking, is it burdensome? I would argue it's ethical not to ask them and not to give them a choice, to be involved or to not be involved. And I'll allude to that in my next few slides. We have a challenge of recruitment, and a lot of these are issues that you would have in any part of any research. So in any project, and no matter what aspect you'd be researching. But sometimes they're multiplied in terms of the difficulties, so you have to be quite innovative in how you address the challenges that will be there. So we do have issues around recruitment. Where are you going to recruit your patients and your participants from? How are you going to recruit them? You know, who's going to be the person? Is it a clinical person? How is that going to happen? Who's going to introduce the project? Timing. When's the right time to do that? And when do you, you know, depending on your research question and what you're doing, can create challenges there. We do have challenges around attrition and retention. So you want to keep people, if you have a longitudinal study, sometimes you don't have a massive window of opportunity for having a study that's over time, but you want to see how the needs change and progress or have measurements over time. So retaining people, because we know again, changes happen. Maybe someone is all keen and then there has been a change clinically in whether the person can participate. And again, it's just multiplied within this context, some of the challenges that we have. We do have challenges around outcomes and measuring outcomes, and a lot of this is linked with prognostication. We know you can have certain indicators that will give us in terms of trying to indicate prognosis and you know, would you be, the surprise question, would you be surprised if this person was going to die in the next 6 months, next year? But you have difficulties in prognostication, and there's always the unknown. A key one you hear from clinical colleagues and families and everything else, and it's a thing that is a challenge to us as researchers because you need to be very mindful of respondent burden. So you have to think that in an ideal world, you might want them to complete 10 screening tools or 10 outcome measures. But in reality, is that too much, you know, to expect someone to complete that amount of data and that amount of information? And there is a challenge around gatekeeping. So while you might build, and I've experienced this in a lot of studies that I've undertaken, that whilst I might have had lots of negotiation with clinical colleagues have worked with me very closely around setting the inclusion criteria and the exclusion criteria for a project. And I think we're all bought in and on the same hymn sheet. And then when they come in to try to recruit and they say, okay, we can get you 30 patients a month, that should be okay, that's doable, going by the numbers that we have coming through every month, and you extrapolate it out, and yet when you come, you don't. And some of it might be different anomalies there, but what I really do have found is this idea of gatekeeping, and other criteria comes in. So Mrs. Smith, she's not quite, so she might meet the criteria as we've agreed, but she's not quite good today. And those aspects that are there, and then challenges of randomization. So I don't have time to go into all of those, but I just want to, I suppose, challenge you in some ways around the challenges. So we do have this paternalistic protectionism. And this quote from Fine's article was that paternalistic protectionism for this vulnerable population, so we know that we're working with a vulnerable group, may have resulted in a paradox. And in the paradoxical effect of not only limiting progress in palliative care, but also intruding upon the rights of the patients to participate voluntarily in research. So what we might have is well-meaning and this idea of paternalistic protection and all out of, but it's a paradox because you're actually limiting the research that's undergoing, but you're also acting to protect, you know, to reduce someone's choice as to whether they want to participate or not. And there is generally a sense of that we have found, and it's noted within the literature, is that people who want to be involved in this, they may well accept that it's not going to have an impact or effect for them, but altruistic reasons to actually have an impact on others and to be involved in research. But the key thing is to make sure people are informed, they know what's involved, they know that they can withdraw at any time, but give people the choice and actually let them make decisions for themselves. And another one is that providing palliative care, that you apply the principles. If you have ethical principles, so what we have found, or I've found in terms of some of the research, is we have to really abide by a lot of, so within the UK, we've I know your ethical approval systems are slightly different here, but we have our, it's all centralised for us. But I have had experience where I've went through ethical review panels, and it's sort of like I've had to be aware of my language. I've had to think about the participant information sheet, what information I have there, what use of terms. But there are ways and strategies that you can still be true to adhering to ethical principles, but also working. So for example, one of the key things I would do is patient and public involvement very, very early on, to ask people to comment on participant information sheets. And ethical review panels there's good practice that you can really build out and infiltrate in what you do around applying ethical principles for recruitment, for retention, for consent. So we know again some of the challenges, again from a research point of view, that will impact on the types of research that we'd undertake. So we know that we have a short intervention time, so it creates difficulties in longitudinal studies. So what you might like to do and think, okay, I'll carry this person over for 6 months, in reality could be very difficult, and repeated measures over time can also be difficult there. Data collection difficulties, so again, access and the timing of, whenever you think what's the best time, is when people come back for review appointments. How does that structure, how does that fit in terms of what's your evidence base for saying every 6 weeks, every 8 weeks? Is that because an appointment happens? How does that fit? It's just, again, it's continually trying to refine the questions for what you're doing. And also outcome measures. So a lot of them can be quite subjective. Now there's a lot of work and development ongoing within this aspect of palliative care, and it's really quite exciting actually to think about the outcome measures of what we use and the rates and which tools would you use, for example, different tools that exist for measuring quality of life, but all like, patient satisfaction and some of those other elements. Some of them can be quite subjective, some of them are looking to use much more validated, internationally recognised tools, and developing the field. If you look now in terms of the field, that's completely developed, that we have a lot of outcome measures, evidence around it, good measurable studies that are building and accumulating on from each other. But in relation to practical challenges for undertaking research in a clinical point of view, or in actually undertaking a research project, there's also strategic challenges. And I'd like us to sort of just touch briefly on some of those. Is that we do have, if you look historically back in relation to funding for palliative care research, in comparison, say for example, oncology and cancer and other areas, the level of funding that we've secured is considerably less, and there's evidence in relation to that. Also, our research activity is very diverse. And what I mean is you can have isolated champions and people working who are doing really good work in their area, but they're not coming together. And again, you hear the saying, the whole sum of the parts, coming together and actually having a collective. So we might have isolated work, but to start to have an impact, needs to be projects that are more internationally, more significant, building collaborations across. We have evidence, but a lot of evidence that's come, so we know what the needs are. We generally have built up over the years a lot of work that is focused on, well, what are the needs of this group, what are the needs of the carers, what are the needs in this context. But we need to get to the point where we're saying, okay, well, what are the interventions now to address those needs? We know the needs, and we generally have enough collective evidence to have that. So what are the interventions that will help to address? So that's a move and a shift in relation to research that we need to be thinking about. Again, absence of critical mass of experienced researchers. And if you look across, and even I suppose these are challenges that we encountered within this context on the island of Ireland before we thought about and building on the palliative care research network, is you might have some strategic leaders and experienced researchers at some end, but we've got to build critical mass and build research capacity for other people coming in, our PhDs, our postdocs, and people building to have this critical mass and have new leaders in terms of undertaking palliative care research. But the challenges around career pathways for people and people going through research in these routes are always there. And a challenge around lack of patient and care involvement. And I'd like you to think about that, because I'm going to show you some results from the review that currently have just come out. And I don't think we've still quite cracked this one yet. We might think we have, and I think we're probably maybe ahead compared to some other areas, but the focus that we really have patient and care involvement completely embedded in how we progress. And then peer collaborations and working in different jurisdictions. But there has been some developments, and some key developments in the world of palliative care research. And I think these are guidance. I'd encourage you to look up some of this. But the More Care project, which was methods of researching end-of-life care. So it gives us some key guidance around guidance on ethics. We've had guidance around mixed methods. We've had a lot of work and development around statistical methods, and then an e-learning module. So these have all been quite significant developments in the field in the last 5 years. We also have this report that came out about thinking about research in hospices. And this was work led by Professor Sheila Payne, and really was tied in with the Hospice UK. And I think some of this, the result, it was a wee bit hard-hitting, this report, but what it was coming out, it was looking at what are the barriers to undertaking research within, say, for example, a hospice setting. But what it found was that there was generally a sense, and that sense was hard-hitting, that there was almost like an apathy, and in some ways nearly even almost hostility to undertaking research within a hospice setting. And all the barriers were noted within there, but what the recommendations very much came through was around thinking about having a research framework within a hospice setting, where you would have 3 levels. So you would have people involved. So research was seen as being central. So the question of this, can hospices afford not to be involved, was the challenge that put out. Because if we say that we're really good and deliver high quality care and really effective, and we have an impact on patient care and all of that, we need to have the evidence to back that up. We need to have the evidence to back it up to take to commissioners. We need to have the evidence to back it up to take to service providers. In the context of a whole workforce model and everything else, we need to have the evidence there. So the question, that's why they titled it that way, is can you afford not to be involved in research? Because there's going to be implications in terms of your organisation and everything else around it. So they advocated 3 levels. You have this embedding a research framework, which was you had people who were aware of research. So it was something that was absolutely all practitioners working within a hospice setting would be aware of different research. You knew the latest pieces of evidence, you were informed. You had people who were more engaged in research, but in research that other people were leading. So actively starting to be involved in research, but not necessarily leading it. And then you had people who were leading research. And for that to happen, they talked about the need to think about having research champions within the hospice, having people who had research within their portfolio, within an element, having a role that was there around it. And the key aspect, and I think this probably fits in with what you're working at, and I think the exciting thing for today is that you need to have links with universities. So you need to have links, and universities need to be challenged to have academics that also link in back to developing the hospice. So I would encourage you to have a look at that paper. I think it's quite exciting. I think it's something as a framework we should be looking towards, but it does give some guidance around some of these challenges. So thinking about Ireland, just remind me of my time if I'm running over, okay. So the question is, what are the priorities, okay, and then what's the state of play today in terms of palliative care research in Ireland? So I just wanted to highlight this project that was finished in January 2015, which was part of a larger Ireland and UK-wide, where it was really looking at and identifying the palliative care research priorities. Now this work was led through Curie, but the All Ireland Institute, we were a collaborator within this and a part funder of this. But the exciting bit about this is it was led by the Jameson Alliance. So the Jameson Alliance is set up where you don't go and ask researchers about what I consider the palliative care priorities, because ultimately I'm going to tell you my area. And I think this is really important because I've spent 20 years doing this. So it was completely turned on the head. It wasn't going to researchers, it wasn't going to academics, it was going to service users and users of the service, carers and health professionals. So it was actually asking them, for them to generate what the priority areas were. And that was quite an innovative approach. It has been used in a lot of other areas, so it's been used, for example, thank you, in optometry, in other areas now. I think there's one currently going on in cancer and in different, Parkinson's, different areas, and dementia. They've tried to really identify what the priority areas were. So it follows this approach. JLA have a method where they set up a steering group. They invite partners to come in. It's very open-ended from the start. So people are asked to identify what areas, and it gathers the questions, what are the areas that you think are important that need researched? And it is as broad as that. From this work, they generated something like 1,400 questions that came through. This was across the UK. Then what they did is they look at the questions that are generated and they compare this to what systematic reviews. So has that question been answered? Is there enough evidence exists around that question? That they were put aside, and then they refined the questions where there wasn't a review, there wasn't any evidence base for it. And they came up with different, it goes through a process of, I think it was 83 questions we had. What you want then people to do is to prioritise these questions. You want to get, okay, of these 80, you can't have all of them. What do you think are the priority aspects there? And then the next stage is that you bring the priorities back to researchers and to funders. So that's the process that was followed. We had LinkedIn from Ireland, so we collected some data. So this was led in the UK and across all 4 countries in the UK, but we were able to collect some data for the south of Ireland and for Ireland. So we pulled this and we had 168 from the last, this is coming to the very last stage, okay? So for the 83 questions, you had a total priority score. Then this was calculated out in terms of the average, and then these 83 were ranked from higher to lower. And then we had a priority workshop. So you use the nominal group, which is where people come together and you have to gain consensus. So I have some pictures of what we actually did here. So we had a workshop, and we had it here. We replicated what they did in the UK. So we had a workshop here in the south where you had people, and we literally, this bottom picture is when you had the 10 questions. And people went into different groups and it came through consensus. Okay, you've now put, these are your priorities. This group is this one. If you really had to, are you happy with what your priority areas were? So we ended up that we have our top 10 priority areas for Ireland. It's very similar to the UK, and it's probably not really a surprise. We have some differences, and I'm not going to go through listing all 10, but the top 5, and this is reverse order, okay, so from the bottom up, the question is, what are the benefits of advanced care planning? 4th was, what are the best way for healthcare professionals to explain the dying process compassionately and honestly? Then we had around pain and symptom relief, top 3. The second one was, what are the benefits and best ways of providing care in the patient's home? So I focused around setting and the home. And the top one is thinking about out of hours. So that's exactly the same as in the UK. The top one is focusing on out of hours. So we were quite excited to see similarities there across. But other areas would be things like education for healthcare professionals. So that's number 10. So there was a lot of argument to make sure that that stayed within the top 10. So I think that's interesting that we still had that there. So we know our priority areas. And now, as I've said, these are priority areas generated by health professionals, users and carers of the service. But what's the state of play of palliative care research in Ireland? So in 2013, I published a paper that was looking at the evidence base of palliative care research in Ireland. And that was drawing on data from the published literature from 2002 to 2012. And I think I have the reference for it here. But that was just for us because we were in the early days of setting up the All Ireland Institute, and we wanted to get a baseline of where are we now. It was drawing on published literature, which can have its limitations as well, which you need to acknowledge, is that that might not be everything that's there, and people undertake PhDs and undertake something else that isn't in the published literature, but it was a way for us to get a sense of what's actually happening. So we know in terms of the Marie Curie in this study is that palliative care research can inform policy and can inform practice. We know that if you think that you have a lot of global atlases that have taken place and a lot of really excellent work from the EAPC that's mapping what's happening in palliative care globally, we don't have the same of what's happening in palliative care research globally. So we know that there's a policy in this country and we know that there's this development, but we don't know what is the state of play of palliative care research. Now, there's been various developments that have taken place in different regions and different countries, And in some ways it's good that we're leading the way in Ireland because we were being cited, because I know Scotland have just published theirs in January of this year. So they're very much replicated our work and built on our systematic review. And we know there's some work in Sweden and China and other countries. But the evidence so far would say that we still have small scale sort of needs-based type studies, and that the more interventional type studies that looked at effectiveness and cost effectiveness were not as apparent, and that we needed to think about investment and think about our funders. So with this context, what I have just completed and just submitted for publication is looking at identifying and thematically synthesizing again. So it's an update of this review, but it's taken over 5 years. So it's looking at 2012 to 2017 and actually see, I suppose ultimately what it was about is, have we moved? Okay, from the previous review, have we moved? So it's a mapping review, and there's some data there around why we would select a mapping review. I have some information around the actual databases. This time we adjusted our inclusion criteria to include PhDs. So we've had some discussion with colleagues in Scotland around their criteria, and we generally felt that we had missed in terms of some of that grey, because you have people who do a PhD but don't actually, just a time lapse in terms of getting it published. So we wanted to include that. We very much wanted to focus this in Ireland, so we had a search term that was around Ireland and Irish, because we needed to be really focused on our search sensitivity. So our inclusion criteria was from 2012 to 2017. More than one or more author who's from an Irish institution. So that was our way of getting, was this conducted in Ireland, and the Irish sense there. Primary research, secondary research, or thesis were included. We excluded commentary papers, editorials, conference abstracts, all of those there. And it was peer-reviewed paper publications and English language. So in looking at it, we had over 1,000 articles that were reviewed, and again, I'll not go into a lot of the detail, but the bottom line was we had 151 papers that we included in the review, and of these 151 papers, they related to 117 studies, and they were included in the final analysis. Just very quickly to give you a sense, we could see that over the 5-year period between this time, we had so we had an increase in the number of publications over the year. The amount of research doubled because we had the same number of publications over a 10-year period as what we had over a 5-year period, which is particularly encouraging for us to hear. And that there was an upward trend, again, in our published papers from 2012 to 2016. Looking at the source of the paper, so again, but it gives you an indication of the quality of the types of publications. If people publish in different sort of journals, we were starting to tap into palliative medicine, and not starting, but we were increased that in terms of palliative medicine, Journal of Pain and Symptom Management. So we know the top sort of journals within our field. So that there was an increase in there. And we also had the PhD thesis were coming through in terms of increasing as well. Funding, no surprise, but the funding source we knew for it, again, we could only go by what the paper had indicated, whether it was a funded project or not in terms of acknowledgement, or whether that didn't exist. So that's important to note. But the most frequent sources were consortiums, were the government, and philanthropic. So when I say philanthropic, I mean charities, type, Irish Hospice Foundation, Marie Curie, those sorts of charities, charitable funding. But interesting, I think, again, to note is that 13% of the research remained unfunded. So that's a factor now. We are slightly less than if we look at compared to Scotland, but still this proportion of research that's been undertaken that isn't funded research. Looking at the methods, again, largely quantitative, qualitative, probably what we might expect. Some intervention studies there, but not as much. One RCT is noted within this time period. So again, that's important to think about. I'd like you to think about this, that we had 35% recruited solely in healthcare professional. So despite my earlier point about thinking about patients and focus on patient cares and all the challenges that I know that go with undertaking research with this group, most of our research that's undertaken, or a third of it, is focused on healthcare professionals and on their views, their experiences in different settings, but focused there. So that's an aspect. Looking at where it was conducted, I suppose a key message here for us is that increasingly we could see research being undertaken across 2 jurisdictions. Given that you have an All-Ireland Institute, that's pretty good that we've achieved that. But also increasingly research that had international collaborations. So to move, and you think back to what the vision of what the Institute was all about, what that was starting to really improve and be bedded in. Most of the research that was there was focused, was the most popular setting was community. Again, think of the policy direction, think of where we're doing about focusing on community. So that's encouraging, but we need to have the evidence base to be coming in. So it's starting, but in the earlier areas. Another aspect was looking at what did they actually focus on. So a lot of the primary research topics, again, starting to think about non-cancer. That was quite a significant aspect, that we had these projects that were focusing on non-cancer and particular groups. Some research focusing around education, training, knowledge. The top 3 themes there about looking at methodology and evaluation as well. Key messages, really, that we've had an upward trend in terms of the number, the quantity and the quality of papers in palliative care research in Ireland. We have evidence of our building capacity, research capacity. The numbers of our PhD students are increasing. We have an increase in review studies, and I think this is quite interesting because instead of everyone thinking we have to go back and do another primary project, we need to be thinking about synthesizing the evidence that already exists. So we are seeing some move to that from 3% to 17%. We have an increase in research activity, but particularly across different jurisdictions and other collaborations. We have some focus on if you map it against the priority areas that were identified, so we have some focus on symptom management. Challenges, a lot of that was physical symptom management. We have some focus on the community. If you think one of the priorities was care in the home, we have some work there. That's an ongoing need. We do have some work on ACP, but these aspects are still missing from the priority areas, ACP and out of hours and those elements. Findings suggest an over-reliance on healthcare professional perspective, so that's something to be thinking about. And then from funding. The funding, we still have an element that is unfunded, and then where the funding has come from over the last 5 to 10 years, but we have the future challenges for us in the north and in the UK, thinking about what are the implications of Brexit. This is the context that we're in, all of the context that goes around that, and what will that mean for future research funding. We need, from a strategic point of view, to be asking those questions. So, very quickly, tell me. Can't even see my time. So, future collaborations, we have networks and the importance of networks. And networks has been noted in the literature, and these are from some pieces drawn from Canada and from other areas, that actually, if you think of all what we want to build up, you need to build that up through collaborations and through the importance of networks. So that's been noted in the evidence around the importance there. But there are challenges in not only starting up, but in sustaining a collaborative. And that some of them come with people. It's all about how you build relationships and how people interact and get on and having mutual respect. People come with different professional backgrounds, different worldviews, different everything, and it's how you build and sustain, and a lot of investment in actually building relationships and trust for people to get to know and respect other colleagues. Another one is about we all have competing demands. So as we were coming, and take the example of through the All-Ireland situation, we were bringing what institutions, and from an academic point of view, institutions that beforehand might have been largely competitors to be collaborators. That has to change in mindset. So that's important to actually think that, and all of us when we're in situations have competing demands because we have to reflect our own institution, but yet we have a commitment to what we want to see happen together, and are committed to that and actually see the importance of working and collaborating together. I've alluded to interdisciplinary, the importance of leadership, to actually have clear leaders to take it forward who have a vision for where we need to go and how we will get there and how can bring other people with them and along that journey. We need funding. And in order to leverage and to have and to make the things happen and to buy in, the importance of having seed funding and continued funding and the funding to support it. I want to just talk very briefly, and I know I see Karen, you're in the room here, but just to give you some sense of the All-Ireland, I have to give a plug, the All-Ireland Palliative Care Research Network. But the idea is that, we have people who need palliative care, we have our partners and our organisations, we importance of integration, and then also thinking about specialist care. So these are the aspects that the research network is focused with. But it's to undertake excellent research that has an impact, and a high impact, that we want to build capacity and have Ireland noted and building on for our future researchers as well. and contributes to these strategic work programs. We want to integrate, and that was always a strength that we wanted to integrate, and I think the whole program this morning integrates the importance of research, integrating into education, integrating into practice. The best questions that come for research come from practice. And there's absolutely no point in doing research that doesn't have an impact on practice, because that's what we have to do. That's what it's practice-based profession. That's what we want to have an impact on patient care. So the importance of having that, and also our users and carers. And that's a challenge, but something that we need to continue and value. And we do, but we maybe need to get that bedded in a bit more. And it's all about supporting and developing specialist palliative care to build on and progress the evidence and the knowledge around that. Internationally recognised in terms of the research network, that we want to be known on the international field and recognised for the research that we do, and that it's all about improving the quality of life of people living with life-limiting conditions, and that's in the broadest sense as well. Key activity areas, as I've said, I'm just going to plug it, but about capacity building, service user care. Karen's here. You can talk to Karen this morning, who can give you more. I'm not going to go into a lot of the detail, but the idea is about building collaborative, coherent research community. We want to be collaborating and focused around today. I do want to touch very briefly on knowledge transfer, because if I said about where we're going in the future, this is a key challenge that we have. So we need to have, while we could have the research and the research evidence base, we need to think about how that has an impact. Within the UK, we have a big piece that's looking about developing impact and thinking about impact in practice. So it's important, there's challenges there around thinking about how you have implementation in practice, and how you have that exchange. It's not one way. It's not like, here's the research. It's like listening and bringing it back and developing and evolving together on the impact. So there's models. So why communicate your research? You've done this research. I've said the challenges. You've went through all that. You've overcome them. You've got your project. You've got your PhD. You've got your master's, whatever it happens to be. So why would you communicate that? Why would you sit and just leave that sitting in a thesis? Why would you not communicate it? Funder, you have an ethical and moral imperative to do this, because you've spent time, but you've been motivated to do it because you know people have given of their time to participate. They've given you their voice. You have an imperative to communicate that out. And when I say communicate it, you can think innovatively about how you might communicate it. Peer review publication, one route, but other ways is important. You want to influence people. You want to have an impact, make a change. So that's why you communicate it, to actually see you can influence perspective. In the academic world, yeah, publish or perish. Maybe for new opportunities, new jobs, whatever. But you want to have, to move away, I think the communication, if we think about communication, it's about listening and refining. So you just don't want it one way. You want to have it two ways. So that's why you communicate your research. Because if I communicate my results to you, may ask me a question that actually makes me refine what I do, or refine how I thought about it, and refine how I reflect it out to another audience. And that's important. I'm alluding to this for the research impact and knowledge exchange. And the idea is it's about two-way communication between researchers and research users. And it's about, I think, knowledge exchange. And I think it's about a mindset. It's about an approach that you value it, you know it's important, and that you see that as your researcher mission as well. I'm highlighting this because it's led through both a colleague here, Suzanne Guerin, who's in the School of Psychology, and this particular model that some of the work for the All Ireland was focused on for knowledge transfer and exchange. I'm not the author of this. I'm just highlighting it. I'd encourage you to have a look. There are references here to this model as well. But what the exciting thing was, it was a particular model. So we know the challenges are around knowledge exchange, but this was a model that was developed and evolved through palliative care research projects. And some of the work was where they had a scoping review. They built on that and looked at case studies of projects that were within the research network, and from that focused on the model that's there. So it's just important. Key things is to know your message, to know your process of how you're going to disseminate your message, and to think who are the key stakeholders you want to disseminate that to. So in my concluding messages, key thing is I do think we need to have research that's informing palliative care practice and informed by the practice. That's vital in what we do. We know the challenges exist. but there's also opportunities, and there's ways to overcome those challenges, and we need to think about those. And fundamentally, we want to build collaborations, we want to build capacity building, and I suppose for us, we want to have continued and the vital for palliative care research in Ireland, that we continue to progress this. Thank you.
So